So this patient, we'll go back to him. Remember, he's 3 years old. At the scene, he was unresponsive, and he required 2 minutes of CPR at the scene. With CPR, his vital signs did return, and he had spontaneous respirations with some intermittent episodes of apnea. He was transported to our facility via ground transport. He had no IV, and he was brought in on the long backboard, no C-color, no bagging, no O2. And so he arrived in our trauma bay, and he was called out as a trauma stat. Again, he was on the backboard, no C-collar. His vital signs when he came in, he had a temperature of 37. His pulse was tachycardic at 130 with a respiratory rate of 21, blood pressure of 92 or 58. He had a Glasgow Coma scale of 7, score of 7. He was grunting, he had some nasal flaring, but equal breath sounds bilaterally. His abdomen was distended and rigid, and his pelvis was stable. He had an abrasion ecchymosis over the left temporal parietal region. And so when he got into our ED, we moved him onto the stretcher and did manual inline stabilization until we could place a C-collar. Since he did have the respiratory distress, he was given O2 and bag ventilated. He got two 20-gauge peripheral IVs. And because of his respiratory distress and as well as his impaired mental status, they elected to intubate him, and he was pre-oxygenated, pre-medicated with etomidate and rocuronium, and intubated using Stort's video laryngoscopy so everyone could see it. Chest X-ray was obtained at that time and was found to have his ET tube in good position, and the rest of his X-ray was normal. And he got a bolus while he was down in the ED, and because of the concern for a head injury, he also got some hypertonic saline. His initial labs on an ISTAT showed a sodium of 138, potassium of 3.9. His hematocrit was 32, and he had a blood gas of 7.33, 37, 37, 19.8, and a base deficit of -6. And his coags were 15.6 with a PTT of 26.6 and an INR of 1.52. And with that, he went to the CT scanner for a head and abdominal pelvic CT, as well as C-spine films. CT of his head did demonstrate significant injuries. He had a subarachnoid hemorrhage along the right parietal occipital scalp and subdural, but he also had an 8 mm contusion of the right temporal region, diffuse axonal injury, non-displayed fracture of the left parietal bone. And his CT of his belly was pretty significant as well. He had a complex grade 4 hepatic laceration with a shattered right adrenal gland with active extravasation, a grade 4 right renal laceration. He had some hyperenhancement of the small bowel with some hematoma and a large amount of hemoperitoneum and a retroperitoneal hemorrhage with some rib fractures. And then he also went for a X-ray of his C-spines at this time, and his X-rays demonstrated a calcific density at the C5, C6 disc space, and there was a question of whether or not this was dystrophic calcification versus fracture. And this will bring up a point which we'll be addressing later about how do you clear the C-spine in this little 3-year-old boy who has a traumatic brain injury. And how are we going to do that? Does he need FlexX films? Does he need CT? Does he need MRI? And who decides on how we do that? And so I think with that, we're going to have Rich talk about some simulation studies.